All the care we are getting at the moment is absolutely fantastic. I can't fault any of them.
I couldn't have done it, I don't think, without all the backups that I've had, you know. I couldn't have done it.
Marie Curie Cancer Care believes that people who are terminally ill have the right to choose where they are cared for and where they die. Most people want to be cared for in the comfort of their own homes, but the reality is very different. Half of all people in the UK are still dying in hospital, which is the place they least want to be. To change this, Marie Curie Cancer Care launched its Delivering Choice programme, which aims to double the number of patients who die at home by improving palliative care services. The programme's most advanced work is in Lincolnshire, where it's already making a huge impact.
Since the introduction of the Marie Curie Delivering Choice programme, we've seen average lengths of stay reducing within the acute trust, and this has had immense benefit both for the acute trust and also for the PCT, in the sense that an awful lot of people are, number one, being deflected away from the acute trust, and those that actually are being admitted are being discharged back into the community in a much shorter space of time. Now, we know that 80% of patients would prefer to stay at home, and the Delivering Choice programme is starting to deliver that benefit to them. So not only is it economically extremely important to us, qualitatively for patients and care, it also has tremendous benefits. I think it's also important to remember that good quality palliative care services are not only better for patients, but they're also more cost effective for commissioners. In Lincolnshire, we're really now beginning to show that the elements of the Delivering Choice programme are becoming core to the delivery of palliative care services within the county, and we need to retain them. We implemented the Delivering Choice programme almost 3 years ago, and in that time we've developed an awful lot of experience. We've experienced challenges and we've experienced successes, but the important message is that we want to share that expertise with other health, social and voluntary sector providers throughout the UK.
In Lincolnshire, as part of the project, it's vital that we have the support of all our project partners, which we do have and we've had right from the beginning. We initiated several key interventions to actually impact on patients' care across the whole of the patient's journey, and that's in hospital, in the acute trust and out into the community. As part of the Lincolnshire project, there are 5 initiatives. There is the Discharge Community Link Nurse scheme, which really helps facilitate and activate quick discharges for patients who are end of life. The Palliative Care Coordination Centre, which is an administrative centre for booking planned care for patients who are being cared for at home. The Rapid Response Team, which responds to urgent and compliant visits for patients to mitigate those crises and really to avoid hospital admissions. The Education Work Stream, which was really key in order to coordinate the education that we have in the county that's already ongoing, and making sure all professionals are aware of what's going on, and also look into the future to think what do we need to have in place to meet the guidance nationally and locally. And wider support for patients and carers to ensure that carers have less feelings of fear and isolation about the situation that they find themselves in, caring for somebody at home at the end of their life.
Sam wanted to stay at home because he wasn't in pain here, but he was in pain in hospital. And we've been together 53 years, never been apart. And one night he was hallucinating, and it was 4 o'clock in the morning and I didn't know what to do. So I'd got all these phone numbers and everything for 24 hours cover with rapid response. So I rang them up and Simon answered the phone, asked me what was the problem. He said, well, we'll come over. And they came, and I couldn't have done it, I don't think, without all the backups that I've had, you know. I couldn't have done it, but I wanted to do it because Sam didn't want to go in hospital. So I nursed him right till the end, and he died in my arms, which is what he wanted.
Before the coordination centre was in existence, the district nurse would go in and do the assessment, and then we would be the ones that would spend time ringing round all the different agencies, finding the appropriate care for the patients. Now the coordination service is in place, they actually do that ringing round for us. They work together both with the district nurses and the patient themselves and the family. And they feed back, and they also tell the patient what care is in place, which actually saves us hours of time that we could actually spend with our patients.
Thank you, bye.
I'm just off to see a patient who's got COPD. He's been looked after at home by his wife. A lot of people don't know, but we go to see anybody with palliative care diagnosis. We can see MND, we can see heart failure, MS, many more. We also provide phone support for carers or patient. They ring up and we talk to them, chat about what the problem is, and often we can sort things out over the phone and we don't need to go to their homes. It's allowed people and their families to stay at home where they really want to be. The Palliative Care Coordination Centre are important because they let us know of patients that have unmet needs. We also work closely with the district nurses. If they're worried about patients or they want us to see a planned visit, we go and arrange and see those visits for them.
Patients that previously would have had to maybe spend the last few days, weeks in hospital are being able to stay at home because they know that there's the care there for them at night should they have a problem. For example, a syringe driver. Should there be a problem at 2 o'clock in the morning with a driver, there's nobody really can get to that patient urgently, and often they would be hospitalised, which is incredibly traumatic for somebody that's maybe in the last stages of their life.
My husband has chronic heart failure. He doesn't want to be in hospital. He needs to be around his family, and he has lots of support from everyone, and everyone's been marvellous. He loves all his family, his grandchildren, and they can come and see him whenever he wants, which is absolutely fantastic.
My granddaughter, when she comes, she's over the moon to see me. The first thing she does, he pops right round the door and waves to me. She's really gorgeous.
When my husband was in hospital, Caroline Boyer, the discharge nurse, with April Gladwin, the Heart Foundation nurse, coordinated with each other to get my husband home, as he didn't want to be there. He wanted to be home with his family, and she was absolutely marvellous in what she did. She helped him to get home. One time when the rapid response team came down, my husband's breathing was absolutely erratic. They came straight away. They were absolutely fantastic. They did everything they could. They're very knowledgeable, very passionate about their work. Well, I can't say enough about them really. They're absolutely brilliant. If anything goes wrong, I know that they're there to call them. And even if they don't have to come down, they're there to talk me through any problems that I have.
I don't look back in the hospital because it's been the second home, and I don't like going. If somebody else can use a bed where I can get all the treatment I want, we've been at home with Marie Curie, rapid response, everybody. I've got the help. All I've got to do is just pick the phone up. If I want anything, it's there. And what more do I need? I've got everything.